Good morning, ladies and gentlemen, and welcome to day 2 of the ILF from sunny Nottingham. We're well aware how busy you guys are, so thank you so much for giving us your time today. It means a great deal to me, our speakers and the team behind the camera. Today's session is called Clinical Particularities of Genital Lymphoedema and New Management Solutions. And our two fantastic speakers are here now, Dr Cheryl Pike and Dr Shelley Dicecco. Welcome.
Thank you.
Are you enjoying the event?
Yes. Very much.
Guys, thank you so much for being here. As you can see, we're live, so if we have any technology problems, please bear with us and we'll get them sorted as soon as possible. As I'm sure our speakers would agree, the more engaged you are, the better, so please make comments, let us know where you're watching from, but also ask questions, and we will endeavour to answer as many as possible towards the end of today's event. Before I begin, a massive thank you to our partners who are THUASNE. Without your commitment to innovation, to research and to independent education like this, these events simply could not and would not happen. So a huge thank you from me and the team. So without further ado, it gives me great pleasure to introduce you to today's first speaker. Over to you, Cheryl.
Thank you very much.
My pleasure.
Good morning, everyone. So as Ed said, our topic today is clinical particularities of genital lymphedema and new management solutions. But we're going to start off, this is just a little general disclosure of who Shelley and myself are. We're looking at an agenda where we're going to just give a little overview of what genital lymphedema is, what types there are, so they're looking at the phenotypes, how to clinically assess and diagnose genital lymphedema, looking at some management tools and some research that has been done, and also looking at what clinical experience we further need. So, overview. If you look at the literature that is existent, we actually don't know what the real numbers of people are that have genital lymphedema. What we do know, and there's a lot of support for this from 2008 already, anyone with bilateral lower limb lymphedema, we need to be asking the question as clinicians, have you got any swelling further up, especially into the genital area? It remains a taboo or embarrassing subject to talk about, but as clinicians we need to be brave to ask those questions so that we can really help this population. We know people who undergo surgery for cancer, whether it's prostate cancer for men or vulvar cancer for women. Those incidences are very high, especially the women. 91% if you have vulval carcinoma and you have surgery and radiotherapy. That's a huge percentage of people who need our help. It is an undiagnosed condition, usually because of embarrassment talking between the doctor and the patient, or the patient and the therapist, and that's why I say as therapists we need to be brave to actually open up these conversations. Even in the literature and in books, genital lymphedema is often not covered efficiently or effectively for us as therapists. So as with any lymphedema, genital lymphedema can present as a primary or a secondary lymphedema. Primary is usually more in men. Secondary can be from a plethora of conditions, cancer just being a small portion of them. Obesity, we know our population is getting larger by size. This is a very real factor in genital lymphedema as well. Furthermore, in my practice, I'm finding people or gentlemen with hypogonadism, again, very high risk to quite nasty scrotal lymphedema. And again, we need to be looking at what other comorbidities are existent, because cellulitis will be a repercussion of genital lymphedema, but it might actually be the trigger, and we need to investigate all of this. So, diagnosing lymphedema of the genital area. There are many things we can do. First of all, the patient's going to report swelling. You also need to look at this, and we'll come back to that in a moment. We also need to know how to describe what we're seeing, because if you can't describe it, how do you know how it changes over time? Thinking of penile edema can present in different ways. It can be an S shape, it can be a J shape, it can be a saxophone shape, or it can be engorged. Penises do not retract into the scrotum. The scrotum gets so big it engorges the penis, so we need to use the correct language. So the scrotum, how big is it? What does it look like? Or what are the skin changes? Thinking of the labia, is it the outer labia, so the majora? Is it the inner labia, the minora? Is the clitoris involved? How high up in the mons and abdomen does it go? How low down in the legs does it go? We need a good clinical picture. The skin changes, fibrosis, pure d'orange, papillomatosis, very common in genital lymphedema that hasn't been managed. You can also get these vesicles. So this is where your lymphatic channels are so engorged, they protrude out. They look like varicose veins, but they're actually varicose lymphatics. And they can present with wounds and ulcers, again, if left unmanaged. Symptoms patients report is that heaviness or pressure in the area. Some can have pain, some can have a dragging sensation, or this sort of bursting feeling. Loads of complications come with genital lymphedema, as with any lymphedema. We've talked about pain, but sexual dysfunction, this tends to be a younger age group, and that's an important factor in life that we need to address. We've talked about cellulitis and skin changes. What about incontinence, especially if that penis is engorged? How are they going to the toilet? Social problems that come with it, because range of mobility isn't good, function isn't good, sitting, standing, walking, getting in and out of the car, those are problems for these patients. So when we're assessing, we need to listen to what our patient's telling us. Really listen, what are their issues, what can we address? Do a general assessment, but there are also specific genital lymphedema assessments, and they're useful tools. They are available to you as well. We need a differential diagnosis so that we can really get together a treatment plan that's fit and purpose to that patient. So the specific genital lymphedema tool, there's a lower limb and genital lymphedema questionnaire for men and for women. Very useful for the patient to complete, because they can actually use the little diagram there to show you exactly where their problems are, and that'll help you make the treatment more specific to them. Again, objectively, have a look, but you also need to have a feel. What exactly are you seeing? What's the panus like? Do your measurements. Use a tape measure. It's really easy to measure the girth or the width, the length of the labia is really useful to keep a track of things, because how are you going to know if it's getting better or worse? We can't just rely on patient reports. Again, palpation, what's pitting, what's non-pitting. Pelvic muscles, what is their function? Is a patient able to hold gas? It's a really simple way of testing it, very crude, but there are ways of examining these things on an external basis as well. We need to do better assessments so that we can have objective measures of treatment, whether it's working or not. So I'm going to hand over to Shelley, who's going to talk a bit more of what you do.
Thank you, Cheryl. So with any other part of the body, we have to incorporate all 5 components of complete decongestive therapy, or CDT. So we're going to go through some of them and kind of give some ideas of how you can adjust your regular CDT for the genitalia. So with MLD, you're going to start it the same way you do with clearing the leg. You're going to start into the trunk. But what you may want to do is pull in a few different lymph node groups to really make sure you have as many pathways out of the region as possible. So those can include your supraclavicular, your axillary, your inguinal, spinal, sacral, your intercostal, and your quadratus lumborum. You definitely want to make sure you're doing breathing, whether you're doing thoracic, abdominal, and diaphragmatic, because the more breathing they do, the more your intra-abdominal pressure will change, and the more you're really getting to those deep lymphatics. As Cheryl talked about, Kegels become very important because your iliac and your sacral nodes are right there on top of your pelvic floor muscles. So the more you engage those pelvic floor muscles, the more you're getting a muscle pump to clean out the lymph nodes. Using your gluteals, because as we'll go through, the genitals are part of your medial thigh, which is half of your gluteals. So by using your gluteals, you're cleaning out that pathway to help move it out, and your abdominals help support in the front, especially your transverse abdominis, and help with your intra-abdominal pressures. You have multiple pathways with the genitalia. You can come superiorly up in front of the trunk, which is usually the most common, but it's also sometimes the hardest because of the fat around the mons pubis. Again, because the medial thigh is the lymphotome that the genitals belong in, you can actually come out the medial thigh into the posterior spine area in the sacral region and bring it all up that direction. Or you can bring the medial thigh and the genitalia over across the front of the thigh to the lateral thigh up into the trunk. Just like with any other part of the body, you're trying to reroute around the dysfunction and avoiding as much of the scar tissue as possible. Whatever pathway you choose, you have to keep in mind the genitals have to be addressed with your MLD before you get to the legs. We wouldn't skip the breast and go straight to the arm. If you skip the genitals to get to the leg, where do you think the fluid's going? The fluid's going to stop at the genital region and is either going to cause genital lymphedema or progress what is already there. So you do need to address them first. Compression. The fun thing about genital compression, as soon as you figure it out, the genitals change shape and now you have to figure it out all over again. With your bandaging, it's whatever will hold. It has to stay on. But the patient has to be able to do it. They have to be able to urinate. They have to be able to change it when they urinate. So they've got to be able to do it, or a caregiver that is with them at all times has to be able to do it. Sometimes we forget the support function, that you can't just put compression bandages on the genitalia and have nothing to help lift it up, because gravity every time they're upright is going to pull on that tissue and stretch it out, allowing more fluid to enter. Your garments also have to be breathable. The genital area is already a warm and moist environment, which is what infections love. So you need to make sure whatever you're using as support or as the garment does have a breathable function to limit the risk of infections. Often during the day, you stick more with garments that are supportive and trying to maintain. And then at night, sometimes you may focus more on the reduction component. So that may be when you slide in the insert is more at nighttime than during the day, or you wear a different type of garment at night to help support and reduce. But again, just like with MLD, you can't compress the leg and not compress the genitals, because again, where's that fluid going when it comes up the leg and into the trunk portion? Gravity is going to pull it straight down into the genitalia. Hygiene, because they're prone to infections, you really do have to go into hygiene more with them than you do often with your breast cancer survivors. You need to explain they cannot reuse the same washcloth on the genitalia more than once. It needs to be washed. A lot of us don't like laundry. We'll try to use washcloths again, or towels. You want to avoid fragrance in the area. Fragrances can actually be irritants with patients that don't even have genital lymphedema, but when they do, it's sometimes worse. You want tepid or mildly warm water so that you are not causing skin irritation or drying it out. Toilet paper sheds. So a quick test is using black pants. Wipe the toilet paper across your pants with the same compression you would do to wipe. If it leaves residue on your white pants, or your black pants, excuse me, it is leaving residue in your genitalia, which can feel like fiberglass to that tissue. So wet wipes are using cool water. Hygiene pads, they're expensive. You have to change them whether they are wet or not every 2 to 3 hours, because it encourages bacteria to move around. You have bacteria come down from the rectum, coming down from the urethra, and vaginal in females. They have a nice little party and they go home with the wrong person, and you end up with C. diff into your bladder. So if they can't afford to buy the products, using the washable ones that are pretty easy to get in most countries now, but it needs to be changed. If they have an infection in the region, they do need to talk with their physicians to find out what's the best course to treat it so that they're not becoming immune to over-counter stuff. Yogurt can help with your own biotics in your body to help with your infection components, especially bladder and GI systems. You've got to talk about sex with your patients. It's a natural part of being a human. You need to discuss lubricants. We want to stick more with the water-based or olive oil. Olive oil is the original lubrication. These will not increase the risk of infections or irritation to the tissues. They do need to use the restroom and actually rinse off and clean off after intimacy. And it's a way to kind of encourage the self-MLD because of the engorgement is to either have it part of the pre or the post intimacy when the partner can be involved. Exercises, same kind of concept as you do with the leg, but you do want to encourage the pelvic floor, and you need to address weight management and include all aspects of CDT. There are available information out there for you to use. You have videos available for both patients and professionals, and there's also courses that professionals can take either online or in person. There was a study done, the ILF study. It was done on 32 patients, 94% which had leg and genital involvement. A little over half were secondary in cause, and a little over half were stage 2. They completed multiple assessment tools and objective measures. The patients wore these shorts with the pads for 12 weeks at day and night, but they also continued their home CDT components. They looked at what was the perceived improvements for both patients and physicians at the end of 12 weeks. And from these two graphs, you can see that both the patient and the physician had significant improvements of moderate and strong at the end of 12 weeks. Almost 2/3 wore the garments for greater than 5 days a week at 50% of the day, and a little under 50% wore them greater than 5 days a week for half the night at least. As you can see from this slide, there was significant improvement, especially in the categories of heaviness, tension, swelling, and urinary disorders, and there was still improvement in the papillomatosis and the lymphorrhea for these patients. The results suggest that there is a clear benefit for wearing the Mobiderm intimates in patients with genital lymphedema. The average was about a 2.7 centimeter reduction in the middle of the scrotum at 12 weeks. As with anything when we're dealing with lymphedema, there's always going to be stuff we can't control, and you're going to have some adverse outcomes. That 57% of the patients that had these adverse events, it was unrelated to the garment. And those that were related to the garment are the same things that we would probably have with anything else we try to put on the patient. You're going to have skin reactions because that area really doesn't love compression. So overall, it was very minimal adverse reactions. And the overall outcome of the study is that 3/4 found it very easy to use. 92% reported that the pressure was actually well tolerated. 93% reported that they provided a comfortable mobility or able to move around, and it was a comfortable compression. 86% of the patients were satisfied, and 96% of them continued to wear the shorts. And they reported by 79% that it's a differentiating solution or another option for them to use. So what is our experience? I've been doing this for over 20 years in genital, and it's still extremely underdiagnosed. It's ignored often by portions of CDT that will only do the compression. I'm not going to massage that. I'm not going to teach them about skin care. There's a lack of access to treatment and supplies. Compression needs more research. We don't have the compression trees that tell us if it's class 1 or stage 1, it's in this compression and that kind of stuff. We don't have guidance on compression. But luckily, it is gaining popularity. You're seeing us at more conferences presenting this topic. So we're hoping that in the near future, more companies like THUASNE will add more products for us to use, and we'll see a different change in genital lymphedema. So we both thank you, and I think we're bringing you back on stage.
You are indeed. Guys, thank you so much.
Pleasure.
I think a really important session, and I'm well aware how much work you guys have put into this, not just now, but over the last few weeks and months. So a massive thank you. And thank you guys for joining us. The last 2 comments I saw were from Canada and Hungary. So you are watching from all around the world, so welcome to you all. You guys okay if I start with the questions? We've got a few that come through. So question 1, I'll start with you, Cheryl, but please, guys, both of you answer. How do you quantify lymphedema in the genitals, and are lymph scanner or other devices effective?
It all depends on what you've got available in your clinical area. Quantifying is about measurements, and you've got to choose repeatable areas. In the literature, they do have specific points you can refer to for both the male and female genital areas, and it's just a matter of repeating them. The lymph scanner or the moisture meter, very, very useful tools, but again, you need to decide on what points you're measuring so that they are repeatable for reference points. Any measurement is only useful if you're able to repeat it so that you can see what the trend is in change.
Fantastic, thank you. Anything to add? Or
I think she covered it really
fantastic. So over to you. Question 2. Is surgery clinically indicated in genital lymphedema management? And if yes, in which cases and for whom?
I think surgery is used too often, that sometimes it's a first line of defense against this, that instead of giving CDT with all aspects involved, we jump to surgery. The problem with surgeries is it's about a 5-year window. After that, they're going to need it again and again and again. And all of that scar tissue you're building up. Would you ask your breast cancer patient to have reconstruction every 5 years on the same area? So really giving it a true, honest effort with CDT. I've reduced several that were surgical candidates according to others, and we've reduced them down where there's been no surgery, there's no sign of lymphedema other than stretched skin, but it's soft, fluid's gone, so it can be reduced. If it's not reducing, it's like other parts of the body. Find another pathway or find another technique. Ask your friends. You can always reach out to us. That really give it a shot before you have these patients go through this painful surgery, which often leaves them unable to participate in intimacy.
Fantastic, thank you.
Can I also add, certainly in Wales, our surgeons are no longer offering surgery to those patients with a massive BMI.
Okay.
So your minimum BMI has to be 52. We've had patients way in excess of that. And ideally the BMI needs to be as close to 30 as possible. And it's not just about the anesthetic risk. It's about lying on your back with your feet in the air. It can cause the muscles to decay during surgery. So those are very real risks, especially for our bigger patients, and we have to be honest with them.
Cheryl, thank you. So question 3, were bandages allowed in the ILMP study? Shall I hand that to you, Shelley?
I don't think
They
so.
didn't do bandaging, they did the,
Compression
because it was
shorts.
considered more of a maintenance kind of component.
Okay.
They did the MLD exercises and that, but they did not do the bandaging component.
Fantastic, thank you. How many sizes does the device Mobiderm Intimate have?
6
Okay.
for both males and females.
And on the boxes is a sizing chart, so it's a really good, useful guide. I remember when I first looked at them, I thought, oh, 6 sizes, that's not very much. But actually, size 6 does accommodate quite a large person. So there's a lot of give in this material and a lot of support. So do try them out.
Brilliant, thank you. So question 5, are there different types of patients or lymphedema specifics where you would use garments rather than bandaging?
I think it's about patient choice. I always give my patients different choices, and it always starts with do nothing. That's something I learned from the consultant surgeons. You can do nothing and just see what happens. You can try your highest level of treatment, which would be your skincare, your bandaging, your exercises, your CDT, MLD, and so on. Or you can say, okay, we'll do skincare. You need to know about exercise. You need to know about weight management. Let's start with a compression garment and see what happens. It has to be patient choice, and it is patient-led. So it's not about the condition. It's about what that patient can manage on a day-to-day basis.
Brilliant, thank you. How can we improve the compliance in genital lymphedema management?
Lymphedema in general is hard for compliance because it is something you have to do every day. You're adding stuff on that can be bulky, heavy, hot, uncomfortable. That it's one of those that education is key, that explaining to them why these different systems or whatever you're using for CDT is working, what happens, what are they looking at. If they're fully educated, it is something they have to make a decision on. That it's just like diet. You go to somewhere that you have brownies or you have fruit. As long as they're educated on what's going on with either of them, as long as they can make the decision, but I find most of mine, once you educate them, are actually pretty compliant, and mine know if they're not compliant, I will discharge them out because I don't have room to keep non-compliant patients.
And at the end of the day, I also say to them, the more you wear it, the better the outcome. It is their choice. You know, we're all adults.
Yeah.
We can only advise as therapists.
Fantastic, thank you. So we have 2 more questions,
Okay.
and then we're done.
Okay.
And you can relax, enjoy, go back to the conference. So question 7, and thank you for the questions that are coming in. It's much appreciated. Regarding the adverse events, are there differences in ILMP versus the other studies with Mobiderm?
Not that I've seen anything with, and I think it's kind of the same as with other garments, that again, you have lymphedema, which is involving the immune system, and it's impacting the tissue health in the area, and they often usually have more comorbidities because of diabetes and other components, that with any garment on any part of the body, you're going to have some adverse outcomes. That I didn't find, looking at all of this, that there was any difference than anything else I've seen with this particular product or other products out on the market.
Brilliant, thank you. So the final question, which is a long one.
Go slow.
No, I will, don't worry. We are seeing patients with hidradenitis suppurativa,
Yeah.
Yep.
with increasing genital lymphedema, with men and women.
Yeah.
What treatment do you suggest at later HS stages? Are abscesses contraindicated to using compression garments?
No.
It's about finding the right dressing for those abscesses. It is about trying to manage the swelling, not forgetting that with HS, as it progresses, you're getting a lot of scar tissue. Fluid gets trapped in scar tissue as well. So it's finding that balance, it's about finding that comfort. Many of these patients, if the HS does progress quite extensively, will need some form of plastic surgery to try and remove the scarred tissue from the abscess. Yeah, you're creating a different type of scar, but if we can stop those abscesses somehow, That is key. These patients need to be under a dermatologist. They need to have the right antibiotics to try and manage any potential infections from the abscess. So you need to work with these specialist teams to get the best outcome for your patient. But HS is very difficult, both for the patient and as a specialist to manage.
The earlier they're seen, the better.
Yeah.
Brilliant, guys. Thank you.
Thank
that
you.
concludes today's session. A massive thank you to you both. Again, a big thank you to the digital team behind the camera. I'm well aware how much effort goes into this, so thank you so much. To THUASNE, as I said before, that commitment to education means the world, and these events don't happen, so thank you from me and the team, and most importantly to you for giving up your time to join us today. Thank you so much. Stay safe, stay strong, and we look forward to seeing you at our next event. Thank you so much, and goodbye.